All right, so thanks everybody for giving up your evening to come and listen to us. So I think that we're starting to shift into the longer term follow-up and the recognition of problems. And you heard a little bit about, for instance, sexual dysfunction, late rectal bleeding, a number of complicated issues which often are more likely to come up in your practice than ours. This oncologist, not very good at asking questions about sexual function and don't tend to do it, and therefore think that everything's okay when it's not. And the general practitioner who hasn't been a fly-in, fly-out specialist that has just dealt with that specific problem, but has known the person more holistically, is more likely to feel a level of comfort. Would you agree with that? Or would you feel that sexual function is something that's as difficult a topic in general practice as it is in specialist practice? What do people think?
Depends if they come together or separately.
Sorry?
Depends on whether they come together or separately.
Yes, and namely which is easier?
Separately.
Yeah, okay. So I guess just the message, and it fits with what I'm going to talk about as well, is that maybe one of the important issues about shared care is that there's quite a useful division of labour here, in that there are certain things that in general practice are going to be done a lot better. And globally in the survivorship space, it's becoming increasingly recognised that issues like management of obesity, hypertension, the teachable moment to change people's lifestyle will often happen as much in general practice when they return saying, Goldstein said he doesn't need to see me anymore for 6 months, but I feel a bit lost about what I should be doing and not doing. And therefore, it's one of the strengths of working towards this shared care is the ability to recognise the benefit from both sides of doing that shared care, and I'd certainly encourage you to consider that. And that's why we wanted to talk to you tonight about the sorts of things that we would want you to help recognise and then interact and discuss with us. So the one that I'm particularly interested in from a research point of view is neuropathy. And unfortunately, oxaliplatin is one of those drugs which has been a real offender, although some of the more recent data might suggest that it won't be as much in the future. How do I get, so you don't get distracted by this? Perfect. Okay, so this woman of 60 who had no prior history of diabetes and renal dysfunction, and that's important because they're risk factors for neuropathy, and it makes us think more carefully if we would see someone with those problems initially. So she had a sigmoid colon cancer resected, unfortunately relatively high stage. She has a 40% chance of recurrence and death in the next 5 years, most of which would happen in the first 2 to 3 years. So concentrates the mind a bit and say, definitely we would like to get our 30% reduction in risk that this combination chemotherapy will offer for you, and offer 6 months of treatment with this combination chemotherapy. And as you heard mentioned by Professor Liao, which I really agree with, is in this woman's case, no symptoms of neuropathy until cycle 8 of 12. So 2 weekly interval, 12 cycles to get you 24 weeks of treatment. So looking good. That's not going to, that idea didn't work.
So, to the bottom.
Which one? Thanks. Okay, so what she started to get was paresthesia that was lasting 4 days, as well as this cold intolerance. We tell everybody, don't drink lukewarm fluids for the first 48 hours, otherwise you'll feel like you're choking when you're not. It's just this exaggerated. I've had people who've gone to Bondi Beach and gone into the water and suddenly got this tremendous shock and gone straight out. So it's an unusual phenomenon. Another one that they all complain about is this feeling of paresthesia and pain when they first eat in that first 24 to 48 hours. We don't actually know the mechanism, but it's almost ubiquitous and quite useful to tell people ahead of time so they don't get shocked about it and come and see you the next day urgently saying, or get rung as I did a month ago, saying, look, we think your patient's having a stroke. And then they weren't having a stroke, they'd just eaten a very cold peach and had this tremendous circumoral cold sensation that lasted 4 hours. They went straight to the emergency room and we kind of sorted it out over the phone. But she still, all her symptoms had gone by day 5. So one of the important things that we as oncologists is, did your symptoms persist for all 14 days till the next day we saw you? And that's an alarm bell. We start to think maybe we have to respond to this. It could be a warning. And certainly if we didn't think about it and they came to you to say that, we would ask you to let us know. And we try to get our oncology day centre nurses as well. In fact, they're so well trained that I get calls now when I'm still feeling comfortable telling me I should be concerned, and that's a good thing. But a month after they'd finished is when she then started to get a glove and stocking sensory deficit that was quite significant. And this kind of very late, what's called a coasting phenomenon, I guess its worst manifestation for me was when a patient of mine, and this was quite early on in oxaliplatin days, where we tended not to adjust anything and we weren't responsive, and went on a cruise with his family and ended up in a wheelchair, unable to walk for the duration of the cruise, and 2 years later was only just starting to mobilise, and yet had not had a single, at least perhaps I didn't ask carefully enough, had not complained once in the whole 6 months of any paresthesia at all. So the coasting phenomenon is a very real and important phenomenon. So she now had difficulty buttoning buttons, she needs help putting on her bra, she drops cups, and she gets some pain and tingling at night that keeps her awake. What did I do wrong? Okay, so the kind of issues I thought we should talk about are, the kind of issues that I thought we should talk about and we've started to touch on are about diagnostics. Very important issue to think about in your practice is about clinician versus patient assessment, and something we've learned a lot from that applies to many other areas of toxicity and applies well beyond oncology. And it is that patient assessments and what we call patient-reported outcomes, which is simply what does the patient think about their treatment or the side effects of their condition, actually carry equal, and in this case more weight, than my ability to recognise the problem. And then there's the question of interventions, and finally the most important is we don't want this to be an issue. We'd like to think about prophylaxis. And those are the kind of important things that I'm going to spend a little time talking about. But I just want to stop for a moment. Does anybody have any experience about patients with neuropathy or experience with a patient of theirs who'd had chemotherapy and complained of some symptoms like this? No? Yes, tell me more.
My father, yeah. Colorectal inflammation, but yeah, it still bothers him. 5 years down.
5 years down the track, and what does it interfere with?
Just fine motor with his fingers, like I said, buttons, writing, touching, small things.
So interestingly, one of the things we try to think of now that perhaps we didn't 10 years ago is what kind of occupation or hobbies do people have? If you're a watchmaker or a violinist or a tailor, I might think a little bit differently and weigh up the relative extra benefit of oxaliplatin And then there's something else we'll talk about in a little bit that I might be more encouraged to offer some people rather than others, trying to minimise social impact afterwards. Okay. So the extent of the problem, I'm really having bad luck tonight. The extent of the problem is quite significant. So up to 50% of cancer survivors, and it's not restricted to colon cancer, breast, ovarian, lung, and hematological malignancies, particularly myeloma, a relatively common hematological malignancy, are all at risk of CPN because of the type of drugs. And it causes long-term deficits. So I think it's just a nice model for us to think about, but that includes many others like sexual dysfunction, late bleeding, abdominal pain, bowel dysfunction. They all fit that idea of late consequences in survivors. And we don't have good methods to identify at-risk patients and the right tools to assess. And most importantly, we don't have neuroprotective drugs. This field is littered with randomised trials that are all negative. And there's not a single drug, preventative drug, yet described, but we keep looking. So the symptoms, as you can see in the bottom right-hand corner, pain, burning, tingling, numbness, an electric shock feeling if you touch something cold, for instance, or go in the water at Bondi Beach, for instance, that paresthesia and temperature sensitivity. There are some tools, it's not all terrible. That's what happens when you don't spend enough time preparing. So neurotoxicity assessment tools. So we have these grading.
Put it on. Click on the thing that you clicked on before.
Oh, presentation. No. Anyway, look, the main thing is clinical severity. There are these clinical grading scales that we all use in the clinic that tell us, help us with grading, which saying something is really bad, not good, or pretty mild and not a problem. And then there are now patient questionnaires, and we would like increasingly to look at patient questionnaires and use them as another guide to impact and negative effects of a treatment. And there are also the tasks. So if you look